Alright, in this video I'm going to cover the topic of delirium. Now, if you're a consult psychiatrist, you're going to get a lot of calls for delirium. People are going to call you from the medical team and they're going to say, this patient came in, she had a UTI, and now she's seeing things or hearing things. She doesn't know where she is, she's not awake, she's not alert, she's not oriented to a person, place, or time, etc. So this is going to be a big place for consult psychiatrists to kind of be aware of what's going on. Basically, delirium is characterized by a decline in both the level of consciousness and cognition, with particular impairment in attention. So that's the important one. There's a particular impairment in attention. So look for difficulty focusing and remaining and attention in the patients that you're assessing. That's one thing. And the classic description is it's a waxing waning level of consciousness. So these patients often have perceptual disturbances, they have abnormal psychomotor activity, and sleep cycle impairment. The hallmark, obviously, like I said, impairment of consciousness, and it's usually with global impairments of cognitive function as well. Abnormalities in mood, behavior, common psychiatric symptoms are also there. Tremor, nystagmus, incoordination, urinary incontinence are common neurological symptoms. So the common psychiatric symptoms, changes in mood or behavior, common neurological symptoms you want to look out for, tremor, nystagmus, incoordination, urinary incontinence, okay? Physicians have to recognize and treat the underlying cause to prevent delirium-related injury. So the whole point of this, in the end, is that when it comes down to delirium, you need to treat the underlying medical condition. That's the key to fixing the patient. So the epidemiology. Delirium is common. In most cases, it's being found in, of course, elderly patients, and in particular, elderly patients that are going to be in the hospital. 1% of the elderly population, age 55 and older, end up having delirium. 5 to 10% of emergency department patients have reported delirium. At the time of admission to the medical wards, between 15 and 21% of older patients meet criteria for delirium. So again, you're seeing how it starts to rise depending on the level of care required, either just at home versus in the emergency department versus admission to the inpatient facility. And delirium has been reported in 10 to 15% of general surgery patients. So obviously patients who are coming in for surgery who are older are going to be at risk. Patients, 30% of open heart surgery patients have 50% of hip fracture patients. That's one of the reasons why you're going to get a lot of consults on, say, the orthopedic floor, is that hip fractures, there's a really, really high incidence of delirium. And it occurs more so than anywhere else, the place you're going to see it the most. And again, these are the sickest patients in the entire hospital will be the ICU. And anywhere between 70 and 87% of ICU patients will have delirium. Advanced age is obviously the most important risk factor for the development of delirium, but also male gender is another risk factor. It's also important to note that while delirium itself is usually corrected whenever you correct the underlying medical condition, it actually is a poor prognostic factor. So 3-month mortality rate of patients with delirium is actually pretty high. So it's not so good. It's estimated at 23 to 33%. So those who have episodic delirium, they actually have a high mortality rate in the 3-month period following it. Some of the etiologies, predisposing factors, like I said, age 65 or older, male sex is another risk factor, cognitive status, so patients with dementia or cognitive impairment or depression, which can be seen as like a pseudo-dementia. Functional status, if they're immobile, if they have a history of falls. Obviously, if there's any sensory impairment, that would be hearing and vision. So that's why we always say that patients who come in, they should get their hearing aids. They should get their eyeglasses if they need them, because those impairments can lead to delirium as well. Decreased oral intake, obviously dehydration, malnutrition, certain drugs, the psychoactive drugs, the anticholinergic drugs, alcohol, and drugs of abuse. Coexisting medical conditions, obviously renal disease, hepatic disease, because you can get renal encephalopathy, hepatic encephalopathy, or uremic encephalopathy, hepatic encephalopathy, metabolic disturbances. You can have strokes, which could be, other neurological problems. Obviously, infections, UTI being a really big one, fractures, in particular hip fractures, and trauma or terminal illness also. Some of the precipitating factors would be drugs, the sedative hypnotics, the narcotic drugs, the anticholinergics, and treatment with various drugs, meaning polypharmacy, alcohol or drug withdrawal also. So alcohol, benzodiazepine withdrawal, etc. Primary neurological diseases, those would be stroke or intracranial hemorrhage or meningitis or encephalitis, and so it's already talked about kind of uremic encephalopathy or hepatic encephalopathy, both of which can present this way. Illness, obviously infections, hypoxia, shock, anemia, dehydration, poor nutrition, low albumin, metabolic issues. The orthopedic and cardiac surgeries being the highest ones, and environmental factors such as admission to the ICU. I already said 70 to 87% of patients admitted to the ICU will become delirious. Physical restraints, which you can see sometimes in psychiatry or in emergency room settings, bladder catheters, pain, emotional stress, or sleep deprivation, all are precipitating factors. One of the good mnemonics for this, if you're trying to seek out what the cause is, which it's a very broad differential and can sometimes be incredibly difficult to figure out, would be called I watch death. So you want to look for infections, withdrawal, and I said alcohol, sedatives, so barbiturates and benzos basically. Acute metabolic, so acidosis, alkalosis, or electrolyte disturbances. Trauma, any closed head injuries, CNS pathology, seizures, stroke, encephalitis, hypoxia, deficiencies in thiamine, niacin, B12, or folate, endocrinopathies such as hypothyroid, glucose, adrenal insufficiency, vascular problems, hypertensive crisis, arrhythmia, suppressed syndrome, toxins, drugs, and heavy metals. So you can use that mnemonic. It's a lot to remember, and it's an extremely broad differential. Diagnosis and clinical features. So almost always caused by one or more systemic or cerebral derangements, and they affect brain function. So sometimes people refer to delirium as acute brain failure. That's kind of a funny term to use for it, but that's kind of what it's like. The core feature obviously being altered level of consciousness. They also have, I said that another salient feature was the attention. They have decreased attention, diminished ability to focus or shift their attention, and impairment in other realms of cognitive function. And they can manifest as distortions to person, place, or time. Decreased memory, relatively rapid onset, brief duration. So these are some of the things you want to look for when you're trying to figure out whether or not this is dementia, say, versus delirium. You want to say to yourself, okay, what's the onset? Is this a rapid change in their mental status, or is this something that happened over a long period of time, such as years? And is it worse at night? And what are the exact problems going on? What are their difficulties? Is it strictly memory, or are they also having problems with their attention? Do they have this waxing, waning level of consciousness? And of course, do they have a medical problem that they're dealing with? Patients can be very disorganized in their thought process. So they can experience perceptual disturbances, they can have things such as illusion, so that's where you mistake one object for another object. They can have hallucinations, they can have psychomotor hyperactivity or hypoactivity. So one of the more difficult deliriums is the hypoactive delirium, because the patients are kind of just sitting there. The ones you get called for tend to be the hyperactive ones, because those are the ones that cause disturbances on a medical floor. Those are the ones that are, difficult for the other doctors to deal with, so you're going to get the call as a psychiatrist for those. And obviously disruptions in sleep-wake cycle and mood alterations. EEG can be useful if you're not really sure. So it usually shows just diffuse slowing of background activity, and those caused by alcohol or sedative hypnotic withdrawal may have low voltage fast activity. So if you're thinking it's more of an alcohol sedative hypnotic withdrawal picture, look for that low voltage fast activity versus the diffuse slowing of background activity. Again, not really specific though. The major neurotransmitters thought to be involved here are, of course, acetylcholine, and the major neuroanatomical sites are the reticular activating system, or reticular formation. The reticular formation of the brainstem is the major area responsible for regulating arousal and attention, and of course that's why you might think that that is the place where some of the derangements are occurring. Diagnosis and clinical features. So the major pathway implicated in delirium is the dorsal tegmental pathway, which projects from the mesencephalic reticular formation to the tectum and thalamus. So that's your major pathway. Again, reticular formation or reticular activating system, probably the most important one in this case to remember. Several studies reported a variety of delirium-inducing factors resulted in decreased acetylcholine, so that's kind of where we got this idea, and hence the concept that anticholinergic drugs can precipitate delirium. So that's where this sort of idea comes into play, that delirium is precipitated by anticholinergic drugs or has something to do with the neurotransmitter acetylcholine. And delirium associated with alcohol withdrawal has been associated with hyperactivity in the locus coeruleus and its neuroadrenergic neurons. Other neurotransmitters implicated, of course, serotonin, glutamate, are also in there. So this is to just kind of show you guys what the acetylcholine pathway looks like. As we know, in the brainstem, acetylcholine originates in the pedunculopontine nucleus and lateral dorsal tegmental nucleus. In the basal forebrain, it originates from the basal nucleus of minor and medial septal nucleus. This kind of just shows you how where the acetylcholine originates from and how it's distributed throughout the brain. And again, acetylcholine being the major neurotransmitter, anticholinergic drugs tend to precipitate delirium, and that's where we get this theory from. And the locus coeruleus I had mentioned is implicated in alcohol withdrawal, so this just kind of shows you where the locus coeruleus is and kind of how those projections spread throughout the brain and brainstem.